Hi, my name is Kelly ONeill. Today I will be reviewing the case of Karen. Karen is a 19-year-old female who presents to the clinic today with a chief complaint of never having a period and painful intercourse. The history of present illness is that since initiating a sexual relationship with her boyfriend, the patient reports that intercourse has been painful. The pain has become so severe that the patient has stopped attempting to have sex. The patient reports that intercourse is the only thing that makes it painful, and that not having intercourse relieves the pain. The patient's boyfriend has reported to the patient that her vagina is awful tight and that he has had difficulty penetrating her vagina. The patient has a past medical history of occasional headaches. Her past surgical history includes an abdominal hernia repair at the age of 4 and a tonsillectomy at an unknown age. The patient takes aspirin as needed for her headaches, and she has no known drug allergies. The patient's pertinent family history includes her mother, alive, healthy, started her period at the age of 13, father alive, being treated for hypertension, sister alive, age 14, started her period at the age of 13, brother 12 alive, sister 11 alive. Additionally, her paternal aunt had a mastectomy. Her maternal aunt is deceased and had probable amenorrhea. Her maternal great aunt is deceased and had probable sexual dysfunction. The patient's social history includes around 3 alcoholic beverages per week. She is an everyday cigarette smoker with a 2.5 pack year history. She drinks approximately 6 cups of coffee per day. She denies illicit substances. She self-reports a healthy diet and engages in tennis at least once per week. The patient's immunizations are up to date. The patient works as a waitress at a local restaurant, which she characterizes as a good job, and reports financial stability. Moving on to the review of systems. General review is the patient denies fever, chills, fatigue, malaise. She denies an intolerance to heat or to cold. She denies a loss of appetite, and she denies any intentional weight loss or gain. She denies any unintentional weight loss or gain. Moving on to the heat, the patient denies any hair loss. She denies facial hair. She denies acne. The patient denies any difficulty swallowing and denies any visual changes. Moving on to the breasts, the patient denies any pain and denies discharge. Moving on to the cardiovascular system, the patient denies chest pain, denies palpitations, and denies lower extremity edema. The respiratory system is next. The patient denies shortness of breath and denies cough. Moving on to the GI system, the patient denies abdominal pain. She denies nausea, vomiting, diarrhea. She also denies constipation. Moving on to the GU system, the patient denies dysuria. She denies frequency. She denies urgency. She does endorse amenorrhea, and she also endorses dyspareunia. Moving on to mental health, the patient denies anxiety, denies depression, denies suicidal ideation, although the patient does endorse concern over the potential inability for her to have children. Moving on to the physical exam, the patient's vital signs are as follows. Blood pressure is 126/80, heart rate is 60, respiratory rate is 16, oxygen saturation is 97%, and her temperature is 98.6. The patient is 5'9", weighs in at 124 pounds, which makes her BMI 18.3. Moving on to the physical exam of the heat, no adenopathy is noted, no hirsutism is noted, the thyroid is small and smooth and palpable, there is no tenderness with palpation, and no nodules are felt during palpation. The exam of the eyes reveals perla and no ocular hemorrhage. Oral mucosa is pink and moist, and her dentition is not impaired at all. Physical assessment of the breasts reveals symmetrical breasts and symmetrical areola. Her nipples are everted. There is no discharge noted. There's no pain or tenderness with palpation, and no masses are felt during palpation. Physical exam of the cardiovascular system reveals regular rate and rhythm and no murmurs. Physical exam of the respiratory system reveals all lung fields are clear to auscultation. Physical exam of the GI system assessments. Abdomen is flat, no deformities are noted, active bowel sounds in all 4 quadrants. Palpation of the upper right and upper left quadrants reveal non-tender abdomen. However, palpation of the lower right and lower left quadrants reveal tenderness and pain with deep palpation, and masses. A mass can be found in each quadrant in the lower left and the lower right quadrants. Physical assessment of the GU system reveals scant pubic hair. Her labia majora could be characterized as underdeveloped, and adolescent. Her labia minora are symmetric, pink and moist. Her clitoris is characterized as small. There is no discharge, no lesions, no rashes, no cysts or masses palpated. The pelvic exam reveals no cervix, no uterus, and a shortened vagina. Mental health, there is no evidence of self-harm. My differential diagnoses include primary ovarian insufficiency, secondary amenorrhea, delayed puberty, and complete androgen insensitivity syndrome. My leading diagnosis is complete androgen insensitivity syndrome, which is an intersex condition. Individuals with this condition are born phenotypically female with fully developed breasts and external female genitalia. The labia and clitoris are sometimes underdeveloped, pubic hair is sparse, and amenorrhea is present, which is the case with this patient. Additionally, intra-abdominal testes are usually palpable, which is the case with this patient. The plan for this patient would be a transvaginal ultrasound, as that is the gold standard diagnostic tool. In addition to basic labs, the clinician should order an HCG, TSH, T4, prolactin, estriadol, testosterone, XY karyotyping, luteinizing hormone, and FSH. It's essential for the clinician to refer this patient to OBGYN, also an endocrinologist for hormone assessment, and a mental health counselor and a family planning counselor. Treatment typically includes surgical removal of the intra-abdominal testes, as these carry a high risk for malignancy, and lifelong estrogen therapy. The role of the primary care provider would be to screen for ongoing mental health issues and substance abuse, as well as monitoring for the side effects of hormone therapy, which can include cardiac issues, GI disturbances, fractures, leg cramping, and breast tenderness. It'll also be important for the primary care provider to encourage bone density testing, self-breast exams, and or mammograms as appropriate. My rationale for the diagnosis of complete androgen insensitivity syndrome is that the patient has fully developed breasts, scant pubic hair, external female genitalia, and intra-abdominal testes, as well as amenorrhea. All of those signs and symptoms are consistent with that diagnosis and are not found in any of my differential diagnoses. In terms of what I missed, a lot. I really wasn't familiar with this condition. And for instance, when I palpated the patient and felt the masses, the bilateral masses in the patient's lower abdominal quadrants, I thought that maybe the patient had masses on her ovaries that were causing these issues. In terms of what I should have done differently, I was concentrating on secondary conditions that would have caused amenorrhea instead of thinking about a primary amenorrhea and what would have been causing that. The parts of the physical exam and the review of systems that I did that were unnecessary were abundant. I didn't really know what I was looking for, so I was just kind of asking everything and assessing everything, and the patient came back with a lot of negative findings, and no, I don't have that, and I've never experienced that, and I don't know, the only reason I'm here is because I don't have any periods and because I have painful sex. So there's a lot of that over and over again, and if it were a real patient, they probably would have felt like they were being super repetitive, and that maybe I didn't really know what I was doing. In terms of pearls, complete androgen insensitivity syndrome is really rare. There are only about 1 case per 100,000 live births, and there have only been about 100 cases reported since 2018. However, secondary amenorrhea is caused by underlying conditions that are really common. Some of those conditions include pregnancy, hypothalamus and pituitary disorders, polycystic ovarian disorder, intrauterine adhesions, thyroid issues, diabetes, and certain medications can cause it as well. Thanks so much for watching my video. I look forward to hearing your feedback and to watching yours as well.